On the next topic of respiratory physiology, we will examine the relationship between volume and pressure. So Boyle's law is a concept in physiology that tells us that volume and pressure are inversely related to one another. This inverse relationship means that as volume decreases, pressure is going to increase, and if volume increases, pressure will decrease. So before we examine the pressures that keep the lungs open, let's look at the forces that are promoting lung collapse. So the first is elastic recoil of the lung tissue. So elastic recoil causes the lungs to want to assume a small size. So think of a rubber band that has been stretched out, and then after you stretch it out, it will return back to its original resting shape and size. So the rubber band does not stay stretched out after it is let go. The other factor is surface tension. So we see that there are thin layers of water in the inner lining of the alveoli, and that water has surface tension, and that tension pulls on the alveoli and makes them smaller. So fortunately, we're going to see that the other pressures that we will examine will work to keep the lungs open. So we'll investigate a few pressures here. The first is atmospheric pressure. So this is the pressure of the air in the atmosphere. So think of it as the pressure caused by the weight of the air on our body. At sea level, the atmospheric pressure is approximately 760 millimeters of mercury. As we go higher in elevation, the atmospheric pressure is going to decrease because there is less air sitting on top of us. So next we'll examine a few pressures that are relevant to the respiratory system. So keep in mind here that if a respiratory pressure is negative, that implies that it is less than atmospheric pressure. If a respiratory pressure is positive, that implies that it is greater than atmospheric pressure. And if a respiratory pressure is equal to 0, that means it is equal to atmospheric pressure. So with that in mind, let's examine a couple of the relevant respiratory pressures. So the first respiratory pressure is called intrapleural pressure. This is the pressure that is created by the adhesive forces of the thin layer of water that is within the pleural cavity, that is between the parietal and the visceral layers of the pleural membrane. This layer of water helps to keep the parietal and the visceral pleura stuck together and helps to resist lung collapse. So think of it another way. The surface tension of the fluid that's in the pleural cavity causes the lungs to stick to the wall of the thoracic cavity like flypaper. So as long as the pleural membrane remains intact and the thin layer of fluid remains inside, the intrapleural pressure will always be slightly less than atmospheric pressure. So we typically see that it has a value of about -4 millimeters below atmospheric pressure. That is 4 millimeters of mercury less than ambient pressure is. So intrapleural pressure is very carefully maintained. That is, the intrapleural fluid is always kept to a minimum. Too much fluid would work against the adhesive forces of the water that the fluid is composed of. We see that, like other tissues, excess fluid is removed by lymphatic drainage, and if too much fluid accumulates, so for example during inflammation or infection, the intrapleural pressure will become positive relative to atmospheric pressure, and we would see that lungs would collapse as a result of that. The intrapulmonary pressure, which is abbreviated P-pul, is the pressure that is within the alveoli. So during inspiration, the intrapulmonary pressure drops to approximately 1 millimeter of mercury below atmospheric pressure, and during expiration or exhalation, the intrapulmonary pressure rises to approximately 1 millimeter of mercury above atmospheric pressure. And we see that between breaths, it's going to equalize with atmospheric pressure. So in this diagram, the intrapulmonary pressure is shown as 0 millimeters of mercury because it has equalized with the atmospheric pressure between breaths. And intrapulmonary pressure represents the pressure that's located in the alveoli of the lungs. So that would be in the pink highlighted regions of the diagram here. Finally, we also see a pressure that's called transpulmonary pressure. And transpulmonary pressure is the difference between the pressure in the alveoli, that is the intrapulmonary pressure, and the intrapleural pressure. So this pressure should always be negative because the intrapleural pressure in a healthy lung should always be lower than that of the intrapulmonary pressure. So if the transpulmonary pressure is quite high, that is more negative, the lungs will be quite large. And if the transpulmonary pressure is low, that is, if it is less negative, or if we see that there is less of a difference between the pulmonary and intrapleural pressures, the lungs will be small. So recall that intrapleural pressure is the pressure created by the adhesive forces of the thin layer of fluid in the pleural cavity. This pressure will always be less than the intrapulmonary pressure in a healthy lung because the intrapleural pressure should be negative in order to keep the lungs open. We see that the lungs will collapse if the intrapulmonary pressure is ever equal to the intrapleural pressure, or if the intrapleural pressure is ever equal to the atmospheric pressure. A condition called pneumothorax will occur if air gets into the intrapleural space, which could lead to atelectasis, which is a collapsed lung. A punctured parietal pleura or a punctured visceral pleura would cause the pressure in the pleural cavity to equalize with the atmospheric pressure, so which again would promote lung collapse. Fortunately, we see that the lungs will tend to reinflate when the pleura heal. So next we will examine the factors that influence pulmonary ventilation. These factors are the surface tension of the water in the alveoli, the airway's resistance to airflow, and lung compliance. So we'll first take a look at surface tension of the fluid that's in the alveoli. So recall that the alveoli contain a thin layer of fluid on their inner surface, and this fluid is critical for the diffusion of oxygen and carbon dioxide across the respiratory membrane. Surface tension is the attraction of liquid molecules to one another at the air-water or the gas-liquid interface. Water tries to resist any force that increases its surface area. So for example, the alveoli expanding would be increasing that water surface area. And so surface tension tries to keep that surface area to a minimum. And therefore, surface tension is promoting the smallest surface area for water. The consequences of this for the alveoli are that water inside of the alveoli will always try to collapse the alveoli. We see that because of surface tension, water can support small objects on its surface, such as this small insect. So how did the lungs go about reducing the surface tension of water in the alveoli? So this would obviously help promote alveoli inflation during inhalation. So remember that we saw that there were type 2 alveolar cells that produced a substance called surfactant. And surfactant is a detergent-like substance that helps to reduce the surface tension of the water in the alveoli. So conditions like infant respiratory distress syndrome are present in infants that are born prematurely because it results from insufficient surfactant production. We see that fetal lungs do not produce enough surfactant until the last 2 months of development before birth. So as a consequence of this, the alveoli, that is if we're not producing enough surfactant, the alveoli must be completely reinflated after each breath, which is going to require a lot of physical effort. This is because the surface tension of the water is too high in the alveoli and it collapses the alveoli between breaths. So we see that this would be an especially difficult task for infants as their muscles are still extremely weak and they're still developing. So this condition can easily be treated by using artificial ventilators, which would generate enough pressure to reinflate the lungs with each breath, or we can treat them with synthetic surfactants. So now that we have looked at the surface tension factor, we can examine airway resistance and how it influences pulmonary ventilation. So recall that resistance is created by friction due to the movement of air along the airway walls. So a small tube with a small diameter forces air through a small space, which causes more collisions of the air molecules with the walls of those airways. We saw this exact same factor with blood flow. So recall that blood moving through blood vessels also encountered resistance as it moved due to the fact that blood is viscous and it tends to stick to the walls of the blood vessels as it moves through them. So it turns out that air also has a viscosity that causes it to stick to the walls of the airways as it moves, although we see that the viscosity of air is much less than the viscosity of blood. And just like with blood flow, airflow is highly dependent on resistance. So because resistance is in the denominator of the equation, that means that if resistance is high, flow will decrease, and if resistance decreases, flow will increase. So therefore, we want resistance to be as low as possible. So let's look at a couple of factors that are responsible for changing airway resistance. So one factor we already examined back when we were talking about blood flow, and that comes from Poiseuille's law. So recall that Jean-Léonard Marie-Poiseuille was a French physiologist and a physicist who did work describing how pipe diameter influences the resistance and flow of fluids, which also includes air, in those pipes. So the following diagram shows the equations for volume flow rate and resistance to flow. So volume flow rate is the top equation, and it is equal to the pressure difference along a specific length of a vessel. So whereas the vessel length is determined as the difference between 2 points, point 1 or P1, and point 2 or P2, which is then divided by the resistance. So because the resistance is in the denominator, we see that as resistance goes up, flow rate will go down, and as resistance goes down, flow rate will go up or will increase. So the second equation is the calculation of resistance, and we see that resistance is equal to 8 times the viscosity, which is represented by this symbol N here, which is the Greek letter eta, multiplied by the length, divided by pi times the radius of that vessel to the 4th power. So because the radius of the pipe is also in the denominator, an increase in radius will decrease the resistance, and a decrease in radius will increase the resistance. So note that the radius to the 4th power is used in this equation, which means that a small increase in radius will lead to a huge decrease in things like resistance. So given we just discussed that airway resistance is lowest in large diameter vessels, you would think that airway resistance would be lowest in the trachea and the primary bronchi, since those are the airways with the largest diameters. However, we see, kind of interestingly, that resistance is actually the lowest at the terminal bronchioles. So even though the terminal bronchioles are microscopic in diameter, their radius is very small, there are many of them. That is, there are thousands of them. And in fact, there are so many of them that the sheer number of them outweighs their really small radius. So we see that depending on which texts, which sources we look at, there are approximately 1,000 terminal bronchioles in each lung, so 2,000 in total. Other sources and texts give estimates that there are about 6,500 terminal bronchioles in total in both lungs, so roughly 3,000 per lung. So we see, regardless of what text or source we look at, that there are a few thousand of these terminal bronchioles. So what factors control airway radius? We see that chemicals, typically hormones, control them, which we'll see in just a moment. We'll have one example here. We also see that the nervous system controls them. So neural control is usually due to the responses of the autonomic nervous system to various stimuli. One example of a physical factor that controls airway radius is an inhaled irritant. So this causes the parasympathetic division of the autonomic nervous system to respond by constricting airway diameter. We also see that things like asthma attacks are acute inflammatory responses to irritants and also provide a physical means for controlling airway radius. Returning to the topic of the chemical factors controlling airway radius, we see that the primary chemical factors are hormones. So for example, the hormone epinephrine stimulates the smooth muscle of the bronchioles to relax, and that causes the bronchioles to dilate. So finally, we can examine lung compliance as our final factor that influences pulmonary ventilation, since now at this point we've looked at alveolar surface tension as well as airway resistance factors. So lung compliance is the measure of the change in lung volume with changes in pressure. So think of this as the lung's ability to stretch when a pressure is applied to them. So compliance is measured as a change in volume over a change in pressure. And if we expose lungs to a specific change in pressure, then we can then observe how much their volume changes in response to that particular pressure change. So lung compliance is directly proportional to lung expansion. So more or greater lung compliance will translate to greater lung expansion, whereas low lung compliance will mean reduced expansion or limited expansion of the lungs. Lung compliance is normally quite high due to the ability of the lung tissue to stretch, just thanks to that elastic connective tissue in the alveoli. And it is also normally quite high due to the production of surfactant by those type 2 alveolar cells. So lung compliance would be reduced as a result of decreased surfactant production, accumulation of scar tissue from chronic inflammation or chronic infections like tuberculosis. Recall that damaged lung tissue is replaced by non-elastic scar tissue, which is going to limit their ability to stretch. We see that it's also due to the reduced flexibility of the thoracic cage.